Good day, ladies and gentlemen, and welcome to your Physician Leadership Forum webinar. All lines have been placed on a listen-only mode, and the floor will be open for your questions and comments following the presentation. If you would like to submit a question at any time during the webinar, you may use the chat box located on the lower left corner of your screen. Simply type your message into the box and click on the send button. If you should require assistance throughout the conference, please press *0 on your telephone keypad to reach a live operator. At this time, it is my pleasure to turn the floor over to your host, John Combs. Sir, the floor is yours.
Thank you very much, Dagmar, and thank you all for joining us today for the AMA-AHA Integrated Leadership Principles webinar. This webinar is brought to you by the American Medical Association and the continuing series of the American Hospital Association's Physician Leadership Forum. My name is John Combs, and I work at the association on physician issues and bringing education and resources to physicians to help develop them as leaders of our healthcare systems. For today's session, we are pleased to have with us a great panel. From the American Medical Association, we have Dr. Robert Waugh and Dr. James Rohack. Dr. Waugh is AMA's immediate past president, the Global Chief Medical Officer at CSC, and a reproductive endocrinologist and OBGYN. Dr. Rohack is AMA's Senior Advisor and past President, as well as the Chief Health Policy Officer and Senior Staff Cardiologist at Baylor Scott & White Health. Also joining us from the AHA is Dr. Jonathan Perlin. Dr. Perlin is the immediate past chairman of the AHA board, and he's the Clinical Services President and Chief Medical Officer of HCA. Both Dr. Waugh and Dr. Perlin will get more extensive introductions a little later on in the program. I'd like to start with a few opening comments about how we got here today and the work that we've done together with the AMA to bring and develop these integrated leadership principles. This collaboration began several years ago when the AHA and AMA recognized they hadn't really done much together in the field of education in the past 40 or so years. Working with the staff at the AMA, we crafted a conference looking at new models of care and their implications around culture, finances, and operations, and did an invitational conference in Washington looking at how organizations were trying to achieve the triple aim through these new models. One of the key findings from this conference was that there was a need for a new type of leadership model for these organizations, one that had a collaborative and integrated leadership between both physicians and the hospital. This journey began back in October of 2013 when we held the conference in Washington. In April of 2014, we published the proceedings from the Joint Leadership Conference and began to have further discussions with the American Medical Association about how we can translate this work into a set of principles to help guide the development of leaders for a new transformed healthcare system. In April of 2014, we published a blog in Health Affairs talking about we need a bigger vote. I was working at that time and was very privileged to work with that time Dr. Jay Crossan. Jay is now the chair of MedPAC, but Jay at that point was a vice president at the AMA. He had just recently retired from the Permanente group as part of Kaiser Permanente, where he wrote and practiced a lot around integrated models of care and integrated delivery system. The title of that article was "We Need a Bigger Vote," really argued to the fact that while the organized medical staff was critically important to the success of hospitals, as we created new organizations that extended beyond the walls of the hospital into the community, we needed to develop an even different model of integrated leadership that broadened the input of physicians and other clinicians into the operation of a healthcare delivery system. We began to work on those principles in 2014, and it had an invitational meeting back in October of 2014 looking at ways to really translate this blog and a white paper on integrated leadership into a set of key principles. Those principles were further defined and was brought to the AMA board and the AHA board in the spring of 2015, and the principles received the approval of both boards at that point in time. Where we are now is we have the set of principles, and you will hear from Dr. Rohack about how we'd like to bring those out to the field and implement them within the field, expanding their reach to not only physicians but other clinicians and other healthcare leaders as well. So what is successful integrated leadership? What are we really talking about? Well, what it requires is a partnership, a functional partnership between organized physicians and the organized delivery system. And Dr. Rohack, a little bit later on, will talk about what it means to be an organized physician group and how that can relate to an organized delivery system. It also requires the ability of all to accept and to manage both the risk of delivering care, the risk of using resources, and the financial risk. And while doing that, managing those risks, improve quality and reduce costs. And then it also requires joint management decisions on quality and population and health between the hospitals and physicians, working together to create the agendas and to find the pathways to solve some of the critical problems faced by our society in healthcare. So what are those principles? Well, there are 6, and they begin with physicians and hospital leaders with a common set of values, a common vision that are incented in the same direction, that are pledged together for shared responsibility for finances, cost, and quality, that work together as a team with accountability, and that share both the planning of strategy and management of the organization. The shared focus must, however, concentrate on patients and engaging them in partners of their care. The second principle was the need for an interdisciplinary structure, a space where those decisions can be made, decisions that affect the operation of the organization and the care of the patients. There is a recognition that clinical autonomy, defined as putting the needs of the patient first, has to be maintained so that the patients are always prime in whatever is done in the organization. And there's needed a place where decisions around quality patient care is coupled with effective and efficient and appropriate care, and decisions can be made about how to get to that end. The third principle is that this integrated leadership has to occur at all levels of the organization. On the front line, with teams of clinicians working with management to deliver care to the patient. At the service line level, where management and clinicians engage in the operation of a service line, a cardiology service, a OB service, but decisions are made jointly about the management, the budgeting, the finances, the human resources of those, and even at the top of the organization, where joint decisions are made about the strategic direction of the organization and the investment of resources of those organizations. The fourth principle is that this partnership must be built on trust. There has to be a sense of shared accountability, shared commitment, and that there is a understanding that the work of the organization and the participants in that organization are all directed to improving the lives of those that we're privileged to serve. We must trust each other's good faith and really work hard at this. This is probably one of the key principles, something that there has been somewhat of a lack of over the years, and it takes a lot of work to begin to build that trust. But part of getting to that trust goes to the fifth principle, which is open and transparent sharing of all information, clinical information and financial information. That we have to really let everyone see what we're doing in terms of our outcomes, or our quality, or our satisfaction, of our financial returns, of our financial investments, and that this has to be shared across the continuum of care. And then finally, there has to be a support system that allows this all to occur, a robust infrastructure that includes a clinical information system, quality management systems, cost accounting systems that help people make very good decisions and appropriate decisions around care and the use of resources throughout the system. This is going to take a new set of skills to do this, and I'm going to have Jim spend some time on talking about how we hope to develop them. But on this slide, you can see that the physician leadership skills needed are really around understanding the focus of the organization, the mission, and the strategy of the organization, understanding what patients and consumers expect from them, the new consumerism that's arising in this country in healthcare, an understanding of the science of quality and safety, how it's measured and how to improve it, how to build teams and work with teams and work within teams, the use of information technology to support decision-making, the understanding of financing, risk, and cost management, the understanding of how payment systems are shifting, particularly now with the macro legislation and the coupling of reimbursement with clinical outcomes and participation in alternative models of care. And then really, what is the role of the individual physician, their patients, in the management of the health of the population? For hospital leaders, it's really an understanding of what it means to be a medical professional, what that says about the work that they do, about the care delivery processes, about how they make decisions. It's putting themselves in the shoes of the clinicians. It's the knowledge of physician practice finances and how physician practice workflow goes, how to achieve consensus working with physicians, understanding that the role of physicians as the individual advocate for patients is as sacred to physicians, understanding the need for physician clinical decision autonomy, specifically to improve the outcomes for their specific patients, putting their patients' needs first, and the willingness to create a true integrated leadership model. These are all skills that both need to learn, and probably optimally both need to learn together. With that, I'd like to turn this over to my great colleague in all this work, Jim Rohack from the AMA, to take us through the rest of the kind of formal presentation. Jim?
Thank you, John. And as John mentioned, the key to this process was trying to bring together systems across the United States that seem to do it right. And when we looked at those, there were some key elements for the physician organization component of integration. Number one is that there needed to have an inclusive governance process that oversaw competencies, both in quality management, practice efficiency, clinical discipline, as well as that clinical and financial management. The second thing that was important for those physician organizations is they had a process for leadership selection, support, and training. It had to be more than just, well, you're the next person up and everybody else has turned it down. Did they really have the ability to have the understanding to be a leader? The third was, how does one join that physician organization? So what are the membership requirements, including professional conduct and clinical protocols? The fourth domain was having a process that develops and review the physician organization's overall strategy, as well as guidelines if there's an employment model or an affiliation arrangement. The next element that was key was having a clinical information technology and resources that were really necessary for effective population as well as patient care management. It's that duality of knowing the individual patient but also taking a look at the population that one is served, having the IT infrastructure to be able to accomplish that. And then as physicians, having a very important member communication strategy and plan that was facile and robust. So when we look at the next comments about what are the cultural needs, and that's found in the next slide, it was clear that there needed to be a focus on the entire population served by an integrated health system, that people were more than just individual components, but you took a look at the whole population that you were serving. And to accomplish that, one needed to have common mission, vision, and values. As John mentioned in many of the principles, a mutual understanding and respect, despite different training and perspectives of the difference between a physician training, a nurse leader training, a hospital administrator training, that what are the commonalities of that, and understanding that we all are trained in a different way. One of the realities of being part of an integrated system is that there is a common ownership to that system and its reputation. And as a result, a joint commitment between physicians and hospital leaders to performance measurement and improvement. Yet at the same time, one has to focus on what's the individual patient care need, not only when they first enter the healthcare system, many times it's through the hospital setting in an emergency room, but they also need time and care that's coordinated across the continuum from home to healthcare facility and then back to home again. What drives this cultural need is performance data, and that data has to be understandable, it has to be timely, and it has to be trusted. There needs to be fair financial and non-financial incentives that are aligned to improve care and manage costs across the organization. It was clear in our discussion of different systems that understanding where the dollars flowed and who benefited and having that open and transparent was one of the bubble-ups that created a very important principle that John just went over. There's a sense of responsibility for that system and a consensus decision-making between all parties. Now, as we developed these principles, it was pretty clear that the needs were there, but there was also some challenges. So what was the challenges that were articulated? Well, one was there really a commitment to transforming in the current business model to a different business model that will be sustainable for the future. There's a recognition there's different mindsets on how to accomplish that. A lack of clarity on the values, their lack of more accessible and generalizable models of physician organization. We have relied on the hospital medical staff model for many decades, driven by the Joint Commission standards on what a self-governing organized medical staff is. But how does that evolve into models where hospitals may not be the only place where patients get complex care? How do we have integrated leadership and management skills? Well, there's a recognition that there's a lack of some skills, as John articulated, between the physician and hospital leaders. There's a recognition for primary care has to be engaged at a very high level and feel like they are part of this new system of care delivery. Payers need to partner with new payment models that will be sustainable as one moves from a fee-for-service to a value-based purchasing model. And of course, we all know any challenge in the United States has legal and regulatory issues that have to be worked through, as well as contractual issues between hospitals and physicians amongst ourselves. The ancillary services issue, who controls the ancillaries? How does that money flow? Has to be worked out with a clear articulation of what's the business model, what's the vision getting forward. And then lastly, the organized medical staff is a very important component of hospital structures. And so having a coordination with them on what is needed, what's the value in the current model, how to get to the next model is important. So as we finish our work together as the American Hospital Association and the American Medical Association, we recognized that there was more people needed in the boat. And so we have reached out, and we're delighted that the American College of Healthcare Executives, who are the ones that provide the ongoing educational structure and competencies for those in healthcare administration, the American Organization of Nurse Executives, whose focus is on that nursing leadership within hospitals and healthcare systems, and the American Association of Physician Leaders, all have agreed to partner with us as we try and bring the tools, the educational abilities, the structure through workshops over the next 2 years, so that on the front lines, people that have recognized the deficiency will have some abilities to improve themselves, and for those hospitals and physicians in communities that want to start down this integrated journey to be able to have the resources both with self-assessment tools as well as then, okay, we've found a deficiency, how do we get to that next level? Our plan is to have a conference in the spring of 2017. Work is being done on that right now, and so more information will come out as this journey continues on. So at this point, I'd like to then stop my formal presentation and introduce Dr. Robert Waugh. As John mentioned his current roles, but Robert is a very important individual because as president of the American Medical Association, he was in this leadership role when our two associations agreed to these principles and was the face and spokesperson for that. Robert brings a unique perspective because of his work as a nationalized recognized expert in health information technology. As mentioned, he's the Global Chief Medical Officer for Computer Science Corporation, but he was also the first Deputy National Coordinator for the Office of the National Coordinator for Health IT, and his 23 years of active duty as a captain in the U.S. Navy Medical Corps showed him how health information technology can bring the globe together, bring people who are caring for people across the globe, bring us together to be able to focus on what's best for patient care. So we're going to stop at this point and turn it over to Robert for his thoughts on our current journey as two organizations focusing on integrated leadership. Robert?
Thank you very much, Jim. And as I start my comments, I want to thank both you and John from the American Hospital Association for all your work in pulling all this collaborative work together and this great set of guidelines for leadership. I also want to note to everybody on the phone that there are 4 physicians on the phone speaking to you today from both the American Hospital Association and the American Medical Association. So I think that's a remarkable thing that's worth noting. The creation of these principles I think, is also an important symbol of the new and improved relationship between the American Medical Association and the American Hospital Association and how we're working together for the betterment of our patients' care and health. There was a lot of symmetry between the discussions of the need to have this collaboration, as well as symmetry as the guidelines were created. The physicians that we know across the country have various practice modes and specialties, so by no means do we expect that these guidelines are one-size-fits-all or that a collaborative relationship is an absolute necessity in every setting. but we thought it was important to put these together to help set a standard and perhaps a roadmap for people who want to form a collaboration together. Clearly, these times are changing, and with the Medicare Access and Chip Reauthorization Act that we all refer to as MACRA, with that replacing the SGR after our big victory in eliminating the SGR last year, the new merit-based incentive program as well as the alternative payment models will, we believe, also support the need for the creation of physician-focused payment models, and that these principles of integrated leadership will be helpful as a roadmap as physicians look how to best to engage with hospitals and new payment and delivery models. For those physicians and hospitals who want to pursue a collaborative relationship, we hope that these principles will serve as a starting point, as I said, to get this process moving. Now, I would also want to say, as Jim noted, my time in the Navy would say that I appreciate all the comments about we have to have more people on the boat. It's very much aligned with my experience in the Navy, but I'd also say that my time in the Navy ranged from being vice chairman of the largest OB department in the Navy to the Pentagon, where I worked on health IT. And one of the things I learned from that as well was the power of unity of effort. And that has to be taken into consideration here in these changing times that we're facing in healthcare. So as physicians and hospitals have a unity of effort that we're working on trying to improve the care and the health of our patients, I think these guidelines for collaboration will go a long ways towards focusing that unity effort towards the problems that we're facing. I'd also say that as an AMA representative, I have to always harken back to our current strategic plan that has three major pillars. The three major pillars of the strategic plan are to improve professional satisfaction and practice sustainability for physicians, to improve medical education for tomorrow's doctors, and finally, and probably most importantly, is to improve health outcomes for our patients. And I think this work that we're having in setting up guidelines for collaboration between physicians and hospitals are very much in line with those three principles. Clearly, professional satisfaction and practice sustainability will be enhanced with a better working relationship between physicians and the hospitals in which they are present. We need to set a goal and a role model for our medical students as they're coming up through their education on how there can be a successful collaboration between physicians and hospitals. And finally, the biggest and probably most important goal of all of this collaboration is, again, as I said, making sure we're delivering the best care for our patients and keeping them as healthy as possible. So with that as just sort of an overview of where we have seen this collaborative effort go, I just wanted to make those comments about where we at the AMA see this relationship, our improved relationship between the American Hospital Association and the American Medical Association. But again, thank you to all that have spent so much time working on this. And it's certainly not a completed project. I think it's a work in progress. We'll continue to work together. But I think it's a great start of a new and improved relationship between the two organizations. And with that, I'll turn it back to Jim Rohack at this point.
And I'll lateral to John Combs to introduce our final speaker.
Thank you, Dr. Warren. Thank you, Jim. It's my great pleasure to introduce to you more fully Jonathan Perlin. I consider Jonathan a good friend, a mentor, and certainly an outstanding leader in healthcare. As I said, he provides leadership for clinical services and improving performance at HCA's 166 hospitals and more than 800 outpatient centers. Current activities include advancing EHR for analytics and data science to inform and improve care throughout HCA. More than just improving core measures, but to get those to benchmark levels and to lead patient safety programs to eliminate preventable complications and health care-associated infections. However, before joining HCA in 2006, Dr. Perlin was the Undersecretary of Health at the U.S. Department of Veterans Affairs. He was really the most senior physician in the VA and in the federal government at that time. He led the VA at a time when they were recognized for truly outstanding care. Dr. Perlin currently serves on the Board of Trustees for the AHA, where he is the immediate past chair, the National Patient Safety Foundation, and the Meharry Medical College. He also served on the boards of the National Quality Forum and the Joint Commission. He chairs the Department of Health and Human Services IT Standards Committee. He's broadly published on healthcare quality and transformation, and he's a fellow at the American College of Physicians and the American College of Medical Informatics. And with that, I will turn it over to Dr. Perlin for his comments.
Well, thank you, John, for your very kind introduction. And let me echo Dr. Wah's appreciation of your work and that of Dr. Rohack in really leading our organizations together in forming these principles. I'd be remiss if I didn't acknowledge my great colleague, Dr. Robert Wah, who worked at the Pentagon while I was at VA, and I know to be really the embodiment of collaborative leadership. And that's really what excites me about this proposition. That said, it's fundamentally true that we are at a crossroads in healthcare, where payment and care delivery models are changing and changing rapidly. The value proposition for delivering care requires that hospitals and clinicians work more closely together to deliver more integrated and more efficient and ultimately better care. Beyond these new payment models, the truth is that the pressures are escalating on reimbursement in the current environment of fee-for-service. Moreover, our desire to pursue the triple aim for better health, better care, and better value offer a real opportunity to create collaborative models of leadership where clinicians and administrators are sensitive to each other's needs and viewpoints and really complement each other's strengths and competencies and experiences. These new collaborative models will take many forms. Some may involve physician employment by hospitals, but many will involve trust-based structures that are built on the ideas outlined in the principles. So the principles transcend current management and clinical structures to provide guidance on creating a team approach to leadership throughout the delivery system. As a physician, I am proud of the fact that this work is a collaboration between the American Hospital Association and the American Medical Association, two organizations that, historically speaking, have not worked as closely together as they might. But just as it was explained in the principles that John and Jim just presented, AHA and AMA leaders recognized the changing landscape and came together to outline these principles to help the field move forward. There are many examples and models where the principles outlined are in fact being successfully implemented. Some organizations like Mayo and Cleveland Clinic have years of experience building the clinic model, while Kaiser has a history of more than half a century of successful collaboration. Other organizations have created models that meet their unique community needs. For example, Advocate Healthcare in Illinois, which has both an employed physician group and a large number of affiliated independent physicians who participate in a clinically integrated network, lead the system together to provide care for the community. Similarly, another example is the longstanding relationship between Mount Auburn Hospital and the Mount Auburn Cambridge IPA, where, while remaining separate organizations, they provide care to their community as an integrated and aligned system. These principles don't just end here, though as we move forward, AHA and AMA are working with healthcare leadership organizations, including the American College of Healthcare Executives, the American Association for Physician Leadership, and the American Organization of Nurse Executives, to align these principles with their core set of leadership competencies to support the effectiveness of team leadership. In addition, AHA and AMA are developing an assessment tool based on the principles for hospital and physician leaders, as well as a set of resources and tools to help launch the principles in their respective organizations. Let me just close with this. Physicians are committed not only to the quality of care and the health of the population, but recent surveys show that nearly all physicians consider themselves, we consider ourselves responsible as well for the cost of healthcare. As well, and reciprocally, health system leaders, whose ranks increasingly include physicians, are committed not only to the value of care and the control of costs, but of course to care quality and the health of communities. The principles really speak to this reciprocity and find their basis in a shared vision, essentially centered on the triple aim and centered most fundamentally around the needs of the patient. They utilize the complementary professional strengths of physician hospital leaders and really remind us and support us in knowing that healthcare is now more than ever a team sport. Having watched the college playoffs last night, it's pretty clear no team plays well without a shared, rehearsed, and well-executed plan, and these principles provide that. But as Alabama demonstrated last night as well, many complementary strengths are necessary to adapt to unanticipated change. And so it's really with this notion of being able to put our strengths together to think about the challenges of the environment, to focus on the triple aim, the care of the patient, the health of the community, the sustainability of healthcare in our country, that these principles excite me in terms of the ability for our organizations to work together and for us to work together to really address the things that we anticipate, but also to be ready for the things that we may face that we don't know about. So thanks so much for letting me be a part of this. I look forward to the continuing discussion and reflect with my colleagues on the pride in our two organizations and working together. With that, let me turn back to you, Dr. Combs.
Thank you very much, Dr. Perlin. Thank you, Dr. Ward, Dr. Rohack, for a great discussion of these issues. Right now, what we'd like to do is open up the lines because we didn't want to speak to you just for an hour. We want to hear your reaction, your comments about the principles and how they may be used within your own organization and where they ring true and where you see some problems with them. So, operator, could you please go out and give instructions on how to do call-in questions? Dagmar?
Thank you. The floor is now open for questions. If you do have a question, please press *1 on your telephone keypad at this time. Questions will be taken in the order they were received. If you are using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. If at any time your question has been answered, you can remove yourself from the queue by pressing 1. Again, ladies and gentlemen, if you do have a question or comment, please press *1 on your telephone keypad at this time. Please hold while we poll for questions.
Thank you very much. And while we're waiting, let me get to a few that are in the queue. One question really asks, I think, the critical issue here is how do you make physicians feel that they're really part of the fabric of the healthcare system and not just workers within the system or cogs within the system? I'd open up that question to anyone.
So this is Jim Rohack. I think it's pretty clear that physicians want to feel that they are part of the system, and so the way that is accomplished is by having shared goals and shared missions. So if physicians have a strong physician organization, they should be able to have an opportunity to interact with hospital leaders to focus on things that are very important for that hospital and or community that they live in. If physicians feeling like they're a peon would suggest that that physician either is not valued or has not been asked for their input to be part of the solution.
You know, one of the shorthand notations for that is a shared sense of ownership, that we're all committed together, we all are going to really make this organization great because we're part owners of it. Is that a concept, Dr. Perlin, that you can see physicians relating to?
Absolutely, Dr. Combs. In fact, I was just thinking that we have on the hospital side had a tradition of deference, but the truth is that that makes an awful lot of assumptions, and I think the new world is really liberating for physicians because while there's commitment to quality and community, the dialogue that opens up really I think suggests ways in which that commitment to quality can be better realized. there's so much opportunity by engaging the physician and hospital leadership in constructive work. It really is a synergy. Sometimes that synergy can be fully expressed through the formal medical staff, but with new models of reimbursement, for example, like bundles, there are dialogues that really don't necessarily have a traditional home in that structure and require a new way of thinking about how to manage health of individual patients, of categories of patients across geography and over time. And it's impossible to envision that a successful dialogue, let alone a successful program, could be realized without this sort of partnership. Rather than starting de novo with a clean sheet, rather than having to reinvent the wheel, I can envision using these principles as really a starting point to convene. And I believe that convening creates a sense of engagement and participation that, frankly, to the question, redresses the inadvertent barriers that may have been created in past times. So this is a really exciting opportunity to address specific issues, but ultimately create an environment that's more conducive to better care, better health, and better value.
Great.
Yeah, this is Robert. I just want to say that, I think that this question about what's the role of the physician is one that is important. And I also want to say that it's been my great privilege to be a physician all these years, and I've never felt like I had a subsidiary role. I've always felt like I was a central part of the system, and I never quite felt like that. So, but I can certainly see the way the environment can have that effect on people, and it's unfortunate that's happening. So these guidelines are, in fact, a pathway forward. Again, I'm also reflecting on my time in the Navy. We as physicians always knew that there, in the Navy, there's a lot of ships and doctors on ships, and there are two people that can turn the ship around, and that's the captain and a physician. And the physician and the captain are always working in conjunction through a relationship that's built on mutual trust and respect to make sure that the health and the welfare of the crew is taken care of. So I see the same kind of environment in many hospitals that, physicians and the hospital leadership are working together for a mutual goal.
Great. Dagmar, is there anyone in the queue right now?
Yes, we have a couple people in the queue. The first question comes from Teresa Rowe-Kurtz from IU National Center. Please state your question.
Hello. As we get more and more administrators, we have too many people involved with how we treat patients, and they're not the ones actually in the exam room. So how do we give physicians the ability to create more of the policies rather than constantly being felt like you're just a cog in the wheel and somebody's always telling you what to do, especially as we have to increase productivity?
So I think this is Jim Rohack. I think that gets back to one of the important principles, which is kind of the shared values and expectations, so that if the goals for financial incentives are not aligned and the metrics are off, then I think physicians may feel like they're just a cog in the wheel and have to see more patients and not really sure what the heck is going on. That's why it's important, I believe, when we were discussing these principles, it was very clear that you had to have transparency and trust. And if it's not there, then you wind up having a situation, Teresa, that you just mentioned, where the frontline physicians are feeling like, well, it's just those people that don't really provide patient care are telling me to do all this sort of stuff, and they don't have a clue on what really is being asked to be done to be able to provide good patient care.
Mm-hmm.
The other point I would make is that if you look at some of these clinically integrated networks, and Dr. Perlin mentioned Advocate, I would also point out Memorial Hermann, and Memorial Hermann, even before it was clinically integrated, was a quality improvement network. In other words, it didn't have any contracts, but it was able to bring physicians to work together on improving care. What you find is if you engage them at that level to make the clinical policy decisions that results in better outcomes that are measurable and where they get feedback, you get much more engagement and a higher level of participation in the management of the overall organization. So as Dr. Perlin pointed out earlier, you have to give physicians meaningful work where they see the impact on the outcomes, and it aligns with how they are rewarded, but also aligns with their professional values in their sense of profession. Operator, we have another question in the queue?
Yes, our next question comes from Joanne Jen from ASA. Please state your question.
My name is Joanne Jenny, and my question is, there are 3 provider groups that I didn't see really focused on in the principles. One are the providers who are non-physician and DOs, such as nurse practitioners and so forth. The second is, where does pharma fit in? And the third is, where do the patients fit into the principles so that they have a ground floor starting point from also being a part of the principles that have been defined?
I think Dr. Rohak pointed out that we are expanding our work now to include nursing as well as the administrative leaders to begin to develop a broader perspective on these principles to engage people in a higher level of team-based care. Critical to that team is the patient itself, and we do mention several times within the principles the centrality of the patient in all of this. But I think as we move forward at all levels of the organization, we're talking about team-based management, team-based frontline care, and in that team are patients and other healthcare providers as well. We had to have a place to start, and we started together as the AHA and the AMA, but I think over the next year or so, you'll see our expanded work into these other areas.
Okay, our next...
Go ahead, Dagmar, sorry.
Okay, our next question comes from Jay Gregory with AMA. Please state your question.
Thank you very much, Dr. Combs, for putting this together. Robert and Jim, nice hearing your voice. And Dr. Perlin, I'm impressed with your football acumen. Maybe we should chat sometime. I have a couple of comments, and I would be interested in the panel's thoughts about this. It is clear to me that there is always a group of physicians, and I don't like the word peons, but that's been used. This group, in my opinion, likes to do their work and go home. This group is the one that's got to be engaged. This group is the one where they have to trust the leaderships and be a part of that process. It would be fantastic if they would attend all of the meetings and say their piece, but that just isn't going to happen because, like I said, they want to come do their work and go home. I don't have a problem with that, but we as leaders must define some way to engage them. Second point, I think it was you, Jim, who made comment about the Joint Commission, and it was the old way and the Joint Commission doing the organized medical staff, et cetera, et cetera. I would propose that there's always going to be a role for the Joint Commission in that we cannot have the fox guarding the hen house because there's always going to have to be an outside body who ensures the delivery of high quality and safe care. Thank you very much for this program, and it's great that we're doing this in conjunction and collaboration.
John Perlin, I'll just give a couple thoughts on this. Let me thank you for your question. Indeed, any organization, and really it transcends professional background. There will be individuals who are leaders and followers. And Dr. Gregory, I think you hit the nail on the head. It's really creating engagement. I think, like it or not, a lot of engagement will be required of us as physicians by virtue of the increasing transparency. It's quite revealing to look at how one is reviewed, whether it's on more formal metrics that are collected by the government. Dr. Rohack alluded to MIPRA and the like, or the less formal metrics that are recorded today on Yelp and otherwise. And that degree of transparency is one of the mechanisms that tends to create engagement. And, what's nice about this, in the words of a physician colleague, a leader that I admire a lot, says, John, in a world of transparency, we're all naked. And if you're naked, you need a really good trainer. This construct, the set of principles, allows for a set of relationships where there is the capacity to have coaching and training, and I think that creates engagement. It raises the standard of play, and the principles, the shared values, really are a higher aspiration in terms of healthcare quality and health of the community, and as I mentioned, the sustainability of healthcare. As you also indicated, there will be any number of external oversight mechanisms in the environment, including the Joint Commission, and I mentioned the degree of transparency. But I think what's also really so promising about this is that this construct, this set of principles, allows the organization, in fact, to potentially think about those things that are shared in terms of values, and can be in some way sort of quantified into terms of measures, and allows then a shared leadership and management responsibility and internal transparency, and better to know your own performance first in practical terms, and second, it is one of those vehicles that does support, as you alluded to, the need for engagement. So I think it's a pretty promising construct for the future for those reasons.
Well, thank you very much. Let me take a question from the chat box, and this is a broad question, and it's to the entire panel. Is the idea of value-based care model a real one? In this model, pricing and reimbursement is based on patient outcomes. Do we really see this happening over the next several years? And of course, we have MACRA out there. It seems like the federal government's serious about it, but do we think this is going to happen across the board in this country? I know nobody likes to be a futurist.
All right, so I'll take the jump ball. This is Robert Waugh. I think part of this is that as physicians, I think we've always sought to make sure that our work and our efforts are yielding the best possible outcome. So, whether we call it value-based care model or any other model, our goal as physicians has been to take the best possible care of our patients to get the best outcome in the most cost-effective and cost-efficient way. So there are a lot of people looking at payment models that are trying to incentivize behavior. As a physician, I think that we need to continue to press for looking for delivery improvements to make sure we're delivering care in the best way. And then I would like the needle to be moved where we speak about payment a little later in the discussion and delivery a little earlier. But at the end of the day, we're all, whether we're talking about payment reform or delivery reform, we're all seeking the same thing, which is to get the best health outcomes for our patients. And so these various labels, I think, can sometimes get in the way. But I do believe that we've always looked for ways to have the best possible outcomes for our patients.
Operator Dagmar, is there any other questions in the queue?
Yes, I see one more, and this one comes from John Vassal from Swedish Health Services. Please state your question.
Hi, John Vassal. Hello, all my friends there. Thank you for putting this together. My question has to do with your allusion. You alluded to the fact that integration or coming together is around physician groups coming together with the health system and the hospitals. And I wonder if you could just elaborate a little bit more on that. And this goes a little bit to Dr. Gregory's question earlier regarding those individual physicians who want to get their work done and go home, who may not be part of a group or a large group. What kinds of groups are you talking about, and how should physicians aggregate in order to interface with their health systems? I know at Advocate, for instance, they do it through what used to be called a PHO with contracting through risk-based contracts. What kinds of platforms do physicians have for aggregating if they're not part of that in order to interface with their health system?
So, this is Jim Rohack, John, and I think you highlight one of the evolving concepts that's still not clarified yet. When you look at the macro bill, they talk about alternative payment models, and as Robert mentioned, focusing on a physician-focused payment model, but all of that has yet to be created. I think there are models across the country. I'm aware of one called the Baylor Scott and White Quality Alliance, where it's an amalgamation of an employed group and independent physicians that have agreed with sweat equity and some dollars to be part of a clinically integrated network. So I think the beauty of the United States and many different practice localities is that physicians will be creative of trying to figure out, okay, how can I come together? To the physician that's out there that doesn't want to join anything and be isolated, it's difficult to see how that model where the physician doesn't want to share a medical record and doesn't want to share accountability is going to be helpful to that physician's patients if they're not being part of the 21st century's information sharing. So I think that's where we believe it's important for us to help those that need some help, and having organizations that can balance the past with the future will be the ones that will survive as we continue to evolve how to best to deliver and pay for healthcare in the United States.
Great. Thank you.
Well, thank you all. And with that question, we've really come to the end of our time together. I want to thank greatly Drs. Waugh, Rohack, and Perlin for really leading this outstanding panel with their great insight and commentary. I also want to thank you all for participating in today's webinar. As a reminder, you can find a recording of this session and the slides on our website at www.ahaphysicianforum.org. Also, stay tuned for information about our next webinar with the American Society of Health System Pharmacists on a very timely topic, the Clinical Pharmacist Chronic Pain Services, Implementing Interprofessional Care. That will take place on Tuesday, March 22nd. And with that, operator, I think it's time to end our call. And again, thank you also for your help.
Thank you. This concludes today's webinar. We thank you for your participation. You may disconnect your lines at this time and